So today we have an extensor tendon laceration, zone 3, coming in. And one of the things I like to do is sort of discuss what it is, what the anatomy is, so that you can have a full understanding. You want to know the protocol of what to do at whatever zones, but the most important thing, I believe, is if you understand the mechanics of the injury. If you understand the anatomy, then you understand the mechanics of the injury. Then even if you don't have the protocol memorized, you can problem solve through the issue. So let's take a look at, it's a extensor tendon. In the prescription, what does it say?
It's a right thumb extensor pollicis longus repair zone 3.
Okay, so we know it's an extensor pollicis longus. So what does the extensor pollicis longus do?
So it extends the thumb IP.
Right, so it extends the thumb IP. So this is where it inserts. So where does it originate?
In the ulna and the interossine membrane.
Right, so pretty much right in the middle of the forearm, basically. So it originates here. What joints does it cross in order to extend the IP of the thumb? So most muscles, especially any kind of extrinsic hand muscle, crosses multiple joints. So it's important to know which joints they cross. So if it originates here, so draw on me.
No. So it originates here.
Right.
Oops, my pen doesn't work. Oh, there it is. It's good.
All right.
If you don't mind. So here.
Mm-hmm.
It'll cross the wrist joint.
That's right.
The MP joint.
Yep.
And then insert.
Right here. Yeah. So this is the extensor pollicis longus. Longus means it's long. So it originates right here, comes all the way across, and it inserts right here. Right? So it crosses, it's going to cross the wrist, it's going to cross the MP, and then it's going to insert into the IP. So when you have a chance, like, that's how you want to study anatomy, right? Because that extensor tendon, you know, okay, it extends the IP of the thumb. So this is essentially what you're having it do. It's going to extend the IP, but it also secondarily extends the MP, also radially deviates the wrist a little bit, crosses. So when you're thinking about an injury that was severed and they sewed it back, what do we know about tendon? And what do we know about tendon healing? Right? So that might be a different kind of conversation, but if we know that tendons don't have blood supply, they need to be sutured in, they rely on scarring and stuff like that to heal, we know that there's a certain amount of push and pull that it's allowed to have in a very specific time period. That's what we know in general about tendons. So if we know that, let's say you don't have the textbook, or you're like, someone comes in and you just, not really sure what to do, you should, from that, because you know the tendon, what should you not be doing? Or what are you not allowed to do?
So you don't want to put it in extreme, you don't want to shorten it, or like
you don't want to, you don't want to lengthen it. You don't want to make it taut. You actually want to shorten it.
You want to shorten it. You don't want to.
You don't want to lengthen it. So you are not allowed to go into
opposition,
flexion, just flexion. You don't want to. You're not allowed to go into flexion of the IP, of the MP, and then of the wrist, right? You don't want to go into flexion or ulnarly deviate, because it's gonna, if you see, it's gonna put that whole tendon, on stretch, right? So if you draw it on yourself, you're gonna see if that tendon goes all the way down into flexion, then it's gonna put a real big stretch on that tendon, right? But if you put the whole thing into extension, then what happens? You've shortened everything, right? So it's a zone 3. Zone 3. Okay, 1, 2, 3. right? So the reason why you need to know your zones, let's see if I can draw my hand. Oh no, you draw it. Why am I drawing it? I know my zones. So take your hand and you can draw it out. Separate your fingers. That way you get some space. Open it up. Perfect. Draw your zones and color code it in.
In orange.
All right, so before you start your zones, you need to, let's kind of erase that. And let's just erase it a little bit. Let's identify where your IP and where your thumb is, right? Because you have to have that first.
Okay.
So where's your IP?
IP.
Right? And then where's your MP? So this is your IP, right? So you have to know your landmarks. Your MP joint, this is your IP joint, okay? You have to know your landmarks in terms of the joints because it directly relates to your zones. So now you can draw your zones. So your zones it includes the joint, right?
Mm-hmm.
You can draw it however you want to draw it. You can color code it, you can do whatever, but you just need to know where 1, 2, and 3 are. Because 1,
3 is like right on the MP.
Exactly. 3 is right on the MP. There you go. That's 3. Right? You can get another color if you want. We've got tons of colors.
Yeah. Green. Here.
So you can. And then 1. There you go. So we know that zone 1 includes the IP. So if they cut it, it's going to be right where is it going to be located. If some doctor says, oh, it's a zone 1 injury, where is it?
On that IP.
Right. It's somewhere here on this IP that they cut. So it's going to be right there. So you know, like, okay, if they repaired it right here, let me not bend them down.
Yeah.
Right? Because you're not allowed to. And now if someone says, oh, it's a zone 2 injury, where is it? Smack in the middle. Exactly. It's going to be smack in the middle of this big old phalange. It's going to be smack in the middle, right? That's zone 2. And zone 3 is going to tell you where. Perfect. So it's going to go over the MP joint. So just by knowing your zones, you know the location of the incision. And you know that's going to be, you know, how far it is, but it's also going to let you know what you're allowed to do and what you're not allowed to do, right? So is that helpful? You got to draw it out and it's going to help you to remember, you know, but when you draw in your hand just to get some practice, always put your landmarks of your joints because it's going to help you a lot in terms of like remembering. Is that helpful? So now that we know some anatomy, right? And now that we know the location of the injury, now we can start to think about, you know, the protocol and what should they need. Now, this is going to need a splint. It's going to need a orthosis. And in your mind, what you want to try to work out is, well, what is it going to entail? It's the extensor pollicis longus. So it extends the IP joint no matter what level, what zone it's in. It crosses several joints. So when you're making a splint, are you making a short hand splint or are you making a long splint?
This one's going to probably be long because it goes through the wrist as well.
Right. So it's got to be long because it's got to stop that tendon from getting pulled into flexion. Right? Yeah. So if it's an extensor tendon, they're not going to be allowed to, you know, flex until a certain amount of time. But if it's an extensor tendon, the extensor pollicis longus, what should it all include? Even if you, this is the critical thinking that you have to do, because even if you don't know the pattern, you should know certain things about what it would include and not include. So what would it include?
So it would include all of the thumb, including
right. So how long is it going to be? How long is it going to go?
So it would be from your forearm, so 3/4 of the forearm.
2/3.
2/3 of the forearm up to block the IP from moving.
So if it blocks the IP from moving, how far should it go?
So a little bit above the IP.
It's got to come all the way.
All the way.
It's got to come all the way over the finger.
Okay.
It's got to come past the nail, because if you don't block the IP from moving, they're gonna move they're gonna try to move their finger, right? If you go just slightly distal to the joint but don't include the whole thing, you don't have enough like support or leverage from the splint to stop the person from moving, right? So that splint, a long splint, it's got to cover, and it's also got to keep the IP in extension, right? So in order to keep the IP in extension, you've got to include the finger, because the proximal phalanx is so small and short. If you don't include that whole thing, there's not enough support, and then that might lag, or that person's going to try to move because they feel like they can. So you've got to take it and you've got to come all the way to the tip of the finger, and it's going to come all the way down to any forearm based splint should be 2/3 the length of the forearm to support the wrist, to stop the wrist from moving, right? Because we need to stop the wrist from moving. It's got to cross the wrist. It's got to obviously cross the MP in order to get the IP into extension, right? So we're going to put just about everything into extension. So the IP goes into extension, the MP goes into extension. The wrist doesn't need to be in extension, but it doesn't need to be in flexion. It needs to be in like a slight extension position. It's a quote unquote neutral wrist position is about 20 to 30 degrees extension. So in this one, I'd go just a little bit more into extension, because then it allows people to like keep their fingers moving, but then protect the thumb. The thumb needs to be not completely radially abducted, nor does it need to be palmar. It just needs to be in that neutral middle position, and then everything in extension. So that's the splint. So that is a zone 3 extensor pollicis longus tendon repair, and it's how you get ready for a case. It's how you problem solve and think through what you need to do if you didn't know the total protocol until you got to the protocol book. My resource is it's the old Indiana protocol book. I just heard yesterday that they're coming out with a new one. It's been a while. So my book's lost its cover, so I might order the new one just so I can have a new book. So this is an extensor pollicis longus repair. Depending on the surgeon that you're working with, at day 3 to 5, you can remove the post-op dressing and then put them in a wrist-thumb static splint with the wrist in 20 degrees of extension, the thumb midway between palmar and radial abduction, and the IP in a joint in slight hyperextension. So pretty much everything in extension, the wrist in that neutral position that I was telling you about, between 20 and 30 degrees. And then within 2 weeks, the stitches come out and you can start scar mobilization. And then within 4 weeks, you can start doing active range of motions that are initiated at the wrist thumb each hour for 10-minute sessions. And then the protocol goes on and on. But basically, just to get started, you need to know what the muscle is, where the injury is, and what zone, which will allow you to start thinking about when you're allowed to do things and what kind of splint that person might need. Now, do you know how long ago this injury occurred?
Yeah, so it's about a month ago, so April 15th, and
yeah,
we're now at...
Yep, so it's about
May
a month.
14th.
Sometimes these cases come in really late, depending on whether they're, they just didn't hear the doctor saying go to therapy right away, or it's an insurance case, like a workers' comp case or something like that. So this is a workers' comp case, and usually in workers' comp case, there's a delay in them getting started. So we know that he's about a month out. He still needs a splint. He still needs it because he needs it for a few more weeks. Yeah. It's usually about 6 weeks, and then you can start to, reduce it. And then we take a look to see, if there's a lag or anything like that. But he still needs it for another 2 months for protection. And if he hasn't gotten any movement, then he might be really, really stiff, really painful. Or he could be on the other side and be like just really great, But most of the time, you can imagine work injuries, depending on where they're coming from, they could be pretty bad saw injuries or laceration injuries. The key thing is just to practice that critical thinking skill of anatomy. Anatomy is like really huge. Anatomy is where if you know where the muscle starts and ends, it's going to help you determine, at least to get started, in terms of what you're allowed to do and what you're not allowed to do. Okay? What's the most important thing when you're doing an evaluation on an extensor tendon repair? Let's talk about our process. This is just how we talk through a case. So we know that this is a work injury of a young man that had an extensor pollicis longus tendon laceration. He had it repaired 4 weeks ago. We don't know how he's going to come. Is he going to come with his post-op dressing that had been changed one time, but still, they'll put him into a somewhat lighter post-op dressing, but they still make it really bulky. So his thumb is not moving, his wrist is not moving. Let's pray that his fingers are moving, right? So in the evaluation, what are we going to do? What's the first thing?
Okay, so you get like the history of the patient. So all their information about just like where they work, if they're currently working or not, any medical history, and then you would, like how they got injured. We already have the information on the date of injury, the date of surgery, and then you would want to go into measuring and taking just measurements to know, like later on, like
right,
to show progress.
Right. So what would you measure?
So we're measuring, like you said, look at the fingers, look at the wrist, is what should be affected.
Mm-hmm.
And
the
nose
thumb.
strength.
And the
right.
thumb.
So the fingers
Yeah.
and the thumb
Mm-hmm.
movement and the wrist. I actually have a question about how much to measure with the thumb.
Okay.
I think he's allowed, so at 4 weeks he's allowed active range of motion.
Right. So that's exactly correct. So if you're looking at what you're allowed to do and what you're not allowed to do, then what you're measuring is based on when they come in. So if it was a new person coming in, I wouldn't really take measurements, right? The thumb would be I would measure the thumb extension, how much extension he should be at, like he's in whatever extension. Because what if he came in and the doctor repaired him so that he needs to be in slight flexion? We would want to know how much extension he has, because the thumb has a lot of hyperextension, right? You want to measure extension. You want to say like he's in 0 extension or he's slightly hyperextended, whatever that number might be. But this guy is at 4 weeks. So what do we know about the protocol of an extensor pollicis longus at 4 weeks? Active range of motions are initiated at 4 weeks for the wrist, thumb. So we know that we're allowed to measure them. So you would tell them what? Go as far as you can go. Bend down as much as you can go. Straighten up as much as you can go.
Keep the wrist like neutral, which would like normal, just normal.
Yeah, because it would just be in a neutral, slightly extended position, just because that's the position that he was in when he came in with the splint. So his position should be here. The wrist is slightly back, and the thumb is slightly back, right into extension. I'm not pushing on it. Yeah, I'm not pushing on it. So I'm not gonna push him into flexion to measure him, but I'm going to measure his active range of motion because I want to know what he's got. I want to know, does he have any tendon excursion? Is his tendon moving? Because if he's coming out a post-op dressing, 4 weeks of not moving, and he's like loop, loop, like moving all over the place, what am I gonna think? I'm gonna think, let me protect this thumb a little bit longer because he doesn't have enough scarring. So we know that if tendons don't scar, you know, really heavily, then you could have a risk for a rupture if someone's too aggressive, right? But if there's no movement, you move, you're like flex, extend, like there's nothing, then you're like, oh man, this one might be stuck. So you're already thinking, you know, what's the tendon looking like on the first move, on that first move, bloop, bloop, what is he looking like? It's like Goldilocks, right? I always talk about Goldilocks, you know, can't be too hot, can't be too cold, it's gotta be just right. So what's right, just right for right now? What's right for just right now is to see, you know, how much motion he has, how much wrist motion he has. Now, I would potentially start on a person who just is first coming in. He has not moved his hand in 4 weeks. I'm gonna gauge how much pain he's in. I'm gonna gauge, yeah, like all the history is important. You know, how did you get injured? Let's reconfirm the date of injury. Let's reconfirm the date of surgery. What have you been up to since then? It's been 4 weeks. Have you been using your hand? What have you been doing? That's gonna tell you a lot about somebody. Oh no, I've been doing all stuff around my house, blah, blah, blah. This thumb is not gonna slow me down. So you already know in your mind, this guy, you might have to slow him down if he's got a lot of tendon excursion. You know, sometimes we work with a lot of men, they get hurt, forget it. They got a nick, like that's it. Oh, you know, I'm not moving for nothing. I'm not moving for nothing. So, you know, you want to see what they're kind of doing. You have to observe when they walk in. That is so key. When they walk into that door, you know, I mean, we have an open concept therapy clinic. Not every therapy clinic has that. A lot of people have a waiting area, and then the therapist goes and grabs their patient, and then they walk down together. You've got to observe what they're doing. You've got to observe how are they picking up their stuff. You got to observe how they're doing their paperwork. Is it their dominant hand, their non-dominant hand? This is just observation. So if they're writing with their right hand and they're sort of trying to hold the clipboard, you know that this person is trying to use their arm. If they're like, nope, it's over here, you already know what you're in for. You kind of already know what you're in for. You know, somebody who's like, nope, this arm is over here. You already know that you're gonna have to work a little bit harder, right? You're gonna have to be a little bit more of a motivator to get them to say, oh, and be reassuring, oh, it's okay. This is what I'm gonna do for you today, but I assure you that I'm not gonna do anything that you cannot tolerate, right? So you got the skittish one, the scared one, the painful one. So you've got to reassure them first that you're not going to do anything to harm them. Today's the first day. We're talking about evaluations. Today's the first day. All I'm going to do is I'm going to take this off. I'm going to take a look at your thumb. I'm just going to see how you're moving. And then we're going to do everything based on what you're able to tolerate, okay? And then from there, then you can talk about what else, you know, and then we're going to just continue to progress until, you know, we get your hand moving as much as we can the way it was before, right? That's a skittish person. You might not have to do that on a guy who's like, you're doing all sorts of stuff and he's moving, he didn't care about his hand or nothing. Might not have to be that slow. You might have to be like, okay, I'm going to take this off. Don't move it yet. You don't want to take something off and he's like, oh yeah, I can do this. And then he goes into way too much motion. So how someone presents to you and how you are observing them from the first second you see them is important. Is it their dominant hand? Is their non-dominant hand? If they're writing, just, you don't have to say, well, is it your dominant hand? Or, you know, they'll switch. And so I saw you writing with your right hand. Are you right-handed? I saw you writing with your left hand. You can go about different ways of asking the same kind of questions, but really you want to, first of all, gauge what they're like. So you in your mind know what you're allowed to do, what you're going to be able to do. So he's 4 weeks, he's allowed to move. I would start with that, gauge what he's like, and then you could start, you want to assess like how much pain he has, and then you see how much his fingers are moving. If he's got really great finger motion, then you're already good. Now you know you have a lot of time to spend on his wrist and thumb. right? Spend on his wrist and thumb. Like, his fingers were not injured per se, and he's not moving them, and they're stuck like Chuck. Then you're gonna take your measurements, and then you're gonna gauge. He might be really painful there, and you might not be able to start there today, you know, to do too much. And you might have to start elsewhere. Fingers, wrist, and then thumb. So how they present to you is such a great way to say, like, where am I going to get started with them? Someone who's really scared, who's really skittish, who's really painful, you can't just pounce on that injury and be like, let's go. 4 weeks, we can do range of motion. They're good to go with everything else, and they don't have any other problems. And yeah, you can go right to that thumb. Okay, we're gonna go right to the thumb. I'm gonna teach you some scar. I'm gonna teach you how to reduce that swelling through massage and work on that scarring so everything starts to move better. And all I'm gonna teach you today is to do some active motion. That means you're moving it all by itself. Don't push on it, because you're not allowed to push on it yet. You know, and as you're doing the evaluation, you start into the treatment, is when in that treatment you're going to talk about the protocol. Okay, so if we do like a hot pack or whatever, which I normally like to do, because if they haven't moved in a while and you want them to move, it just kind of eases them into the treatment. So, you know, like a good 5 minutes or whatever. Now, 5 minutes, you know, we're going to take the hot pack off, and I'm going to teach you a few ways to safely move your finger so that you can start moving, but we're not going to damage the repair the doctor did. Because guess what? If you rupture the repair, if you're too aggressive, if you're too aggressive, then you're going to have another surgery to fix it, right? Secondary repairs, you know, after a long time is not good. But if you don't move it in a very specific way and that it's stuck, then you're going to have another surgery to unstick the tendon. So we have to move in a very deliberate way to get that finger, to get that thumb moving in a way, but without injury. So I'm going to show you what that's going to be like. And then you just go from there. So the first day, there's a lot of stuff. There's a lot of things to cover in terms of safety, splinting, protocol, and home exercise. But when it comes to home exercises, man, I keep it real simple. Bring them back the next time. First day, there's a lot of information. Don't brain dump on the patient everything that they need to know, because there's a lot of information. You know, it's hard for someone who doesn't work in the health industry and has never had an injury like this before and have had surgery. If you're telling them so much information, they may not be able to remember it all. It's okay, because they're going to come back and you're going to be able to help them.